Imagine peeling back the layers of a master craft, understanding not just the outcome, but the intricate step-by-step process, guided by years of experience and, well, distilled into a precise manual.
Hmm.
That's exactly what we're doing today. We're stepping into the operating room, not as patients, but as observers, exploring the incredibly detailed world of orthopedic surgery through the lens of the surgeons themselves.
Quite a unique viewpoint.
Our source material is a fascinating peek behind the curtain, a textbook compiling standard operative dictations and essential procedural steps for common surgeries across the human body.
Yes.
Think of it as the collective wisdom, the refined playbook shared among practitioners to ensure consistency and excellence.
It truly is a distillation of applied knowledge.
Yeah.
It's not theoretical. It's the practical how and why documented by surgeons. Our mission in this deep dive is to truly appreciate the sheer level of detail, the deliberate planning, and the systematic approach required in these procedures, revealed directly through these documented standard practices. It's a way to gain a unique understanding of the modus operandi, the method of operating, that defines this field.
And guiding us through this complex landscape is our expert, ready to synthesize this dense information and provide those critical insights. Let's get started.
Happy to be here to explore the precision required in surgery. It's quite something.
So this book exists for a reason. The preface lays out its purpose very clearly. It's much more than just a collection of notes, isn't it? What problem is it trying to solve, or what goal is it aiming for?
It's definitely not just notes. The authors are quite explicit. Their fundamental goal is to enhance our medical practice and provide the necessary knowledge to be utilized in a competent medical practice.
Right, so straight away it's about quality.
Yes. This immediately tells you the focus is on improvement and practical application. It's about raising the standard of care across the board.
And they describe it as creating a modus operandi. That phrase feels very deliberate in this context.
It is. Establishing a modus operandi, a standard method of operating, is crucial. They recognize the need for guidance, particularly for new clinicians and medical practitioners.
Oh, for those just starting out.
Exactly. The motivation, as they state, was to facilitate surgical procedures and minimize inquiries and confusion prior to starting surgeries. Think about a busy operating room. Clarity and efficiency are paramount.
Of course.
Having a standard approach documented reduces ambiguity and saves critical time.
So it's partly about operational efficiency and reducing potential for error or delay when everyone understands the expected flow.
Precisely. By setting a clear model, providing templates for operative dictations, it helps surgeons at all levels, residents, fellows, even experienced practitioners, structure their thinking and documentation. It's about creating a shared mental model, really. They aim to compile enough data so that a trainee could participate constructively in the surgery. If you know the expected sequence and critical steps beforehand, you can be a more effective member of the surgical team. It builds shared understanding and predictability in what is inherently a high-stress, high-stakes environment.
It's like having a standard checklist and playbook everyone agrees on before game day.
That's a good analogy. And the book strongly sheds light on the importance of details in the operating room. The authors aren't just documenting steps, they emphasize that these details are functional.
How so?
They play a key role in making the surgeon's life easier and enhance the surgical performance. By meticulously documenting preferences, specifying all detailed preferences for every particular procedure crucial for the surgeons, the book captures nuances learned through experience.
Right, the little things that make a big difference.
Yes. This acknowledges that while the core steps are standard, refining them with specific, proven details is part of mastering the craft.
So it's a deep well of collective experience, distilled into a format that promotes precision, efficiency, and education by standardizing the minutiae. Looking at the sheer scope, it covers a vast territory. Spine, pelvis, hip, knee, leg, foot, ankle, elbow, forearm, wrist, hand, shoulder. Quite comprehensive.
Correct. The book is organized anatomically, covering a wide range of common procedures. The fact that multiple authors contributed, as the preface notes, brings together diverse experiences to shape these standardized approaches, adding layers of refinement. You get different perspectives, you see.
Okay, before a single incision is made, the book emphasizes a significant amount of groundwork. This seems absolutely critical. What does that meticulous preoperative process look like according to these dictations?
Well, planning and preparation are foundational, a principle stressed across almost every procedure described. It really begins with a comprehensive assessment of the patient and their specific injury or condition.
Assessment meaning understanding the problem fully, gathering all the facts.
Yes, exactly, and drawing information from multiple sources. The text consistently refers to taking a detailed history, performing a thorough physical examination, and utilizing a variety of imaging studies.
So not just x-rays.
Oh, much more. These aren't just administrative checks. The findings from these studies are the blueprint for the surgical approach. For example, standard x-rays are fundamental, yes, but they also use MRI for staging conditions like a vascular necrosis, looking at tissue death.
Right.
CT scans for complex fracture patterns, seeing the bone in 3 dimensions. Scanograms, specifically for measuring leg length discrepancies or precise deformity angles.
So getting the measurements just right.
Precisely. Crucial for procedures like high tibial osteotomy or correcting tibia shaft deformities, and even discograms to pinpoint the sorts of pain in spinal fusion cases by injecting dye into discs under X-ray guidance.
So each type of scan gives different information.
Each imaging modality provides unique, critical data that informs the plan. It's all part of building the picture.
Right, gathering all the necessary intel to build the tailored approach. What kind of specific planning details are mentioned beyond the imaging?
The text delves into specific preoperative planning steps that go beyond just looking at images. For procedures like total knee arthroplasty or high tibial osteotomy, it talks about templating radiographs.
Templating, what does that involve?
This involves using acetate overlays or digital software on the patient's x-rays to estimate implant sizes, plan the location and angles of bone cuts, and predict postoperative alignment before stepping into the OR.
So you're essentially doing a dry run on the x-ray.
In a way, yes.
Uh-huh.
They also detail determining the precise size of an opening wedge needed for osteotomies, essentially deciding exactly how much to cut the bone and spread it open to correct alignment.
Okay.
For tibia shaft deformities, it means identifying the center of rotation of angulation, or core ara, which is the geometric point around which the deformity correction needs to hinge. This isn't just looking at the problem, it's quantitatively planning the solution, calculating the exact spot.
It sounds like precision engineering applied to the human skeleton. Really detailed stuff.
It is, very much so. Then comes patient preparation and positioning, which is described with remarkable attention to detail. Patients are positioned in specific ways depending on the surgery. Supine, just lying on their back.
Okay.
Prone on a Wilson frame, for spinal surgeries to flex the spine and improve access. Lateral decubitus, lying on their side for hip or certain lumbar spine fusions. Or supine on a fracture table, which uses traction and specific supports for procedures like fixing femoral or tibia fractures.
Fracture tables sound quite specialized.
They are. Shoulder procedures often use a semi-sitting beach chair position. For some fractures, a radiolucent operating table is used, allowing x-rays through the table, often with bolsters or bean bags to help maintain position. Getting the patient stable and accessible is key.
And the repeated mention of padding pressure points seems vital. That comes up a lot.
Absolutely, it's a non-negotiable step, explicitly stated multiple times. Care was taken to protect and pad all pressure points. This is crucial to prevent injury to nerves, like the common peroneal nerve at the fibular head, which is quite vulnerable, or skin breakdown during what can be lengthy procedures.
Right, people can be under for hours.
Exactly. They note very specific positioning needs, such as carefully protecting the non-operative extremities, isolating the perineum with sterile drapes for pelvic or hip procedures, or flexing the operating table itself to open up the space between the ribs and pelvis, the costoiliac region, for certain anterior spinal approaches. Every detail matters for safety and access.
So even before the first cut, it's a process of precise diagnosis, detailed measurement, careful patient setup, and proactive protection. A lot happens beforehand.
Precisely. Add to that the standard medical preparations. Administering anesthesia, whether general, regional, like a spinal or epidural, or sometimes local for procedures in cooperative patients. Prophylactic antibiotics are routinely given intravenously before surgery begins to significantly reduce the risk of infection.
Standard practice, then.
Yes. 4 vilines and Foley catheters for bladder drainage are placed where indicated. Standard stuff, but essential.
And the strategic use of a tourniquet is a recurring theme in limb procedures. Tell us about that.
Yes, a tourniquet, usually on the thigh, for leg procedures, or the arm for upper extremity, is a critical tool. Its primary purpose is exsanguination, making the limb bloodless.
How do they achieve that?
Well, it's done by elevating the limb to let gravity drain the blood,
Oh,
or by using an Esmarch bandage, which is a rubber bandage wrapped tightly from the fingers or toes upwards to push the blood out before the tourniquet goes up.
right.
Once the limb is exsanguinated, the tourniquet is inflated to a pressure above the patient's blood pressure.
Huh.
Pressures like 220 millimilli G, 250 millimilli G, 300 millimilli G, or even 350 millimilli G for higher level amputations are mentioned.
And the benefit?
This creates a bloodless field, which is essential for clear visualization and precise work. You can see exactly what you're doing without constant bleeding obscuring the view.
Makes sense.
But critically, the total time the tourniquet is inflated is meticulously tracked and recorded in the operative report because prolonged tourniquet time can lead to nerve or muscle damage.
So keeping that time noted is a key safety measure. You can't just leave it on indefinitely.
Not at all. It is. Now, here's a detail that really struck me and highlights the level of foresight. The repeated mention of using fluoroscopy before prepping and draping the patient.
Before they haven't sterilized the area, why
Right.
that specific timing? That seems counterintuitive.
This is a crucial workflow step that prevents major headaches later. Fluoroscopy uses a mobile X-ray unit, a C-arm, to get real-time images. You position the patient, and then you go in the C-arm to make absolutely sure you can get the necessary views of the anatomy you need to operate on before you commit to a sterile field.
Ah, so you check, you can actually see what you need to see first.
Exactly. Can you see the specific spinal levels you plan to fuse? Can you get the right angles to work on the distal tibia? Can you visualize the hip properly on the fracture table? If you discover you can't get adequate views after you've prepped and draped, well, you have to break your sterile field to reposition the patient, which wastes time and increases infection risk significantly.
I see. So it's a fail-safe.
It's a proactive check. It ensures you have adequate visualization, confirms correct levels in the spine, checks positioning for things like SCFE, that slipped hip condition we mentioned, without trying to force a reduction, or allows assessment of an initial closed fracture reduction before you make your incision. It's a proactive step to ensure the rest of the surgery goes smoothly.
That's a fantastic example of how experienced surgeons build checks into the process to mitigate predictable problems. Okay, with all that meticulous groundwork laid, we move to the surgical approach itself, accessing the target area. How does the text describe navigating the body's complex anatomy?
Well, it's about creating a planned pathway, not just cutting randomly. The dictations describe a variety of incision types and precise locations, chosen deliberately based on the underlying anatomy and the goal of the surgery.
So different cuts for different jobs?
Precisely.
Yeah.
You see midline longitudinal incisions over the spine, longitudinal incisions for accessing long bones or specific tendons, transverse incisions for things like excising wrist ganglia, where the scar needs to be less noticeable cosmetically,
Right.
and even zigzag incisions in the fingers for digital nerve repairs, specifically designed to cross flexion creases at an angle to prevent scar contracture, which can limit movement later on.
Clever.
And for minimally invasive procedures like knee or shoulder arthroscopy, small portals are made, tiny incisions.
So the incision isn't just a generic cut, it's the deliberate start of a specific route to the problem.
Exactly. And that route involves carefully layered dissection. You move through skin to the subcutaneous fatty tissue, and then you encounter fascia. The text highlights different types of fascia depending on the region, the thick fascia lata in the thigh,
Mhm.
thoracodorsal or lumbodorsal fascia in the back, sartorial fascia in the knee, deltoid fascia in the shoulder. Below the fascia, you might encounter muscle, and finally you reach the periosteum, the tough, fibrous membrane that covers the bone.
Moving through the tissues layer by layer, almost like an anatomical roadmap. Very systematic.
And often, the text emphasizes using specific anatomical intervals or carefully splitting muscle fibers rather than cutting across them. This is done to minimize trauma to the muscle tissue, preserve its function, and reduce bleeding.
Protecting the muscle as much as possible.
Yes. Examples include using the deltopectoral interval in the shoulder, that's the plane between the deltoid and pectoralis, major muscles splitting deltoid fibers to reach underlying bone for a biopsy or curettage, or accessing the ulna bone along its subcutaneous border by splitting the interval between the flexor carpi ulnaris and extensor carpi ulnaris muscles. This level of detail shows the anatomical precision required.
What stands out here is the deep understanding of functional anatomy required just to get to the problem area with minimal damage. It's not just about knowing where things are, but how they work together.
It's absolutely foundational. And throughout this dissection process, there is a constant overriding imperative: identifying and protecting vital structures, particularly nerves and blood vessels. The dictations repeatedly emphasize this vigilance.
It sounds like this is where the real danger lies if you're not careful. What specific structures do they mention needing to protect? It must be a long list.
The text lists many, highlighting the regional risks. For example, protecting the ulnar nerve is crucial when operating around the elbow or the medial side of the wrist. The genitofemoral nerve needs careful protection during anterior lumbar fusion approaches. In anterior cervical spine surgery, the recurrent laryngeal nerve is a key structure to avoid damaging that affects the voice. The saphenous nerve and vein are vulnerable during procedures on the medial knee or ankle. The superficial peroneal nerve needs protection in distal tibia or foot-ankle fracture surgery. For hand procedures, the digital nerves and arteries are meticulously identified and protected tiny structures.
Hmm.
The radial artery must be carefully retracted during approaches to the volar side of the wrist. In anterior lumbar fusions, major vessels like the aorta and iliac vessels, as well as the ureter and sympathetic chain, are explicitly mentioned as structures to be protected. Big stuff.
Indeed.
Behind the knee, during tibial osteotomies, the posterior neurovascular structures, that's the popliteal artery, vein, and tibial nerve, are highlighted. In shoulder surgery, the axillary nerve, which wraps around the humerus neck, and the musculocutaneous nerve are identified and protected.
It really is a complex web of vital structures that must be navigated safely, almost like a minefield.
Well, it requires constant awareness and specific techniques. Surgeons use various retractors, which are surgical tools used to hold tissues away from the surgical field to help shield these structures. The text mentions types like Charnley retractors used in hip surgery, Holman retractors, Cobra retractors, Jaws retractors, malleable retractors, which could be bent to shape.
Tools for the job.
Exactly. And for spine surgery, a Dorico nerve root retractor is specifically used to gently move nerve roots out of the way without damaging them. Blunt dissection, using instruments to gently push tissues apart rather than cutting them, is another technique employed to separate structures safely.
So the approach is a carefully planned journey through the body's layers, guided by deep anatomical knowledge, using specific tools, and maintaining constant vigilance to protect critical nerves and vessels.
Precisely. It's a controlled and highly intentional process. Nothing left to chance, ideally.
Right, now we reach the core of the procedure, actually addressing the underlying pathology, whether it's a broken bone, a damaged joint, or injured soft tissue. How does this textbook describe the execution of these diverse tasks? This is the main event, so to speak.
This is where the specific techniques vary widely depending on the problem, but they all share that underlying principle of precise execution. Let's start with bone fixation, which often means putting broken pieces back together and stabilizing them.
Fracture reduction, getting the pieces aligned. How is that accomplished? It sounds tricky.
It can be. The text describes different methods. Sometimes it's simple manual traction applied to the limb, like for a supracondylar femur fracture in a child. For certain femoral neck fractures, hip fractures, specific closed reduction maneuvers are described, like the Ledbetter technique or the Whitman technique, which involves specific movements of the leg. For other fractures, reduction is achieved under direct visualization once the fracture site is exposed, such as in a distal humerus fracture fixation. For fractures like an ankle fracture, manipulation might involve using tools like a reduction awl. Clamps or tenacula are often used to temporarily hold bone fragments together, while plates and screws are being applied, for example, during high tibial osteotomy or forearm fracture fixation.
And there's a specific detail about SCFE, that slipped hip condition not performing significant reduction. Why is that?
Yes, that's a critical point in the dictations for a slipped capital femoral epiphysis, SCFE. The text explicitly states not to perform significant or forceful reduction or traction before fixation. This is because attempting to fully reduce a severely displaced slip can disrupt the tenuous blood supply to the femoral head,
Ah, the blood supply.
leading to a vascular necrosis, which is the death of bone tissue due to lack of blood flow. It underscores that the technique is highly specific to the injury, and prioritizing blood supply preservation is key. Sometimes accepting a less than perfect reduction is safer.
Right. So once reduced or accepted in that SCFE case, fixation hardware is applied. What types of implants are commonly mentioned?
A wide variety are detailed. K-wires, Kirschner wires are used frequently for everything from provisional fixation, just holding fragments temporarily,
Okay.
definitive fixation in certain bones like fingers or wrists, acting as guiding pins for drilling or nail insertion, or simply to help check reduction and alignment under fluoroscopy. They're very versatile.
And screws?
Screws are fundamental and come in many forms. Lag screws, used to compress fragments together. Cortical screws for dense bone shafts. cancellous screws for the softer bone ends, locking screws which lock into plates for construct stability.
So they don't back out.
Exactly. Cannulated screws with a hollow core allowing insertion over a guide wire, which is very useful for accuracy, and partially threaded screws. The text describes how they are applied using standard AO compression principles, filling all screw holes in a plate for maximum stability, using specific guide systems, or sometimes a freehand technique guided by fluoroscopy.
And plates and intramedullary nails. Those sound like the heavy-duty option.
They often are, yes. Plates are used to bridge or compress fracture fragments. The text mentions types like 13 tubular plates, L-shaped plates, and LCDC plates. Their placement is specified posterolateral or lateral for fibula fractures, on the anterior aspect of the humerus, or specifically on the ulna and radius for forearm fractures. Intramedullary nails are strong metal rods inserted down the central canal of long bones like the femur, tibia, or humerus.
Right down the middle of the bone.
Precisely. The steps are described. Inserting a guide pin across the fracture, reading the canal to the appropriate size to fit the nail snugly, often done in 0.5 millimeter or 1 millimeter increments.
Gradually widening it.
Yes. Inserting the nail itself and then placing interlocking screws through the bone and nail to prevent rotation and shortening. Proximal screws may use a target device, while distal screws often require a freehand technique guided by fluoroscopy, sometimes using the perfect circles technique where the drill is aligned until the circular opening in the nail appears as a perfect circle on the X-ray screen.
Wow, that's clever geometry in action. External fixators are also part of the orthopedic toolkit mentioned. When are they used?
Correct. For certain fractures, particularly those with significant soft tissue injury or open fractures, where putting plates or nails inside might be too risky for infection, external fixators are used.
So keeping the hardware outside the main wound area.
Exactly. This involves placing pins or wires into the bone fragments away from the injury site and connecting them with an external frame. This provides stability while allowing access to manage the soft tissues. The text describes pin placement and frame assembly for things like distal radius or complex distal tibia fractures, sometimes using hybrid ring fixators, which are quite complex structures.
And throughout all this hardware application, how is the surgeon confirming everything is in the right place? You mentioned fluoroscopy before.
Fluoroscopy is used extensively and repeatedly. It's used constantly to check the reduction of the fracture and the position of the hardware in real time. They obtain AP, anterior, posterior, lateral, and sometimes orthogonal views at 90 degrees to each other to confirm alignment in multiple planes.
Checking from all angles.
Yes. They check that screws aren't penetrating joint surfaces, verify that guide pins and nails are centered in the bone canal, confirm the path of screws, and ensure accurate placement of interlocking screws, often using techniques like that perfect circles method mentioned for distal tibial or femoral nailing. Constant visual checks.
Okay. Moving from fractures to joint reconstruction or fusion, big operations like hip and knee replacements.
Yes, arthroplasty or joint replacement is detailed for major joints like the hip, knee, and shoulder. The general process involves carefully exposing the joint, removing the damaged articular cartilage, and sometimes sections of underlying bone, precisely preparing the remaining bone surfaces to accept the implants using reamers, saws, or burrs.
Shaping the bone.
It's exactly. Trialing components, inserting temporary plastic or metal components to check for proper fit, size, range of motion, stability, and limb alignment or length. Then finally, inserting the definitive metal and plastic components.
And the choice of using cement is mentioned, cemented versus uncemented.
Yes, some components are cemented into place. This involves preparing the bone bed, applying bone cement like polymethyl methacrylate in its doughy phase, often using a cement restrictor or plug in the bone canal to prevent it from going too far down, pressurizing the cement into the porous bone, and then carefully removing any excess cement before it hardens.
Okay.
Other implants are uncemented or press fit, designed with porous surfaces that allow the patient's bone to grow into the implant over time, providing biological fixation.
So the body integrates with it.
That's the idea. The text also notes specific targets for implant orientation, such as aiming for specific degrees of acetabular anteversion and lateral opening for a hip replacement to optimize stability and range of motion, or achieving a certain degree of femoral anteversion. Getting the angles right is crucial for function.
And arthrodesis, or fusing a joint. Why would you fuse a joint?
Arthrodesis procedures, like fusing the ankle joint or performing a triple arthrodesis in the foot, fusing 3 specific joints, are done to eliminate painful motion and provide stability, often when a joint is severely arthritic and replacement isn't suitable or desired.
So sacrificing movement for pain relief and stability.
Essentially, yes. This involves removing all the remaining articular cartilage and a layer of subchondral bone from the joint surfaces. The exposed bone surfaces are then fixed together in a functional position, usually using hardware like screws or plates, and often bone graft is added to encourage the bones to grow together across the joint, creating one solid bone.
Turning to soft tissue repairs and transfers the muscles, tendons, and nerves that surround the bones and joints seems just as complex.
Oh, absolutely. The text includes procedures on these vital tissues. For ligamentous instability, repairs are described, such as the Brostrom reconstruction for chronic ankle instability or an open Bankart repair for shoulder instability, often involving using suture anchors.
What are those?
Small implants placed in bone with sutures attached. And strong sutures or tapes are used to reattach torn ligaments or capsular tissue to bone. Tendon procedures are detailed, like a biceps tenodesis, finding the biceps tendon, freeing it from its attachment in the shoulder, preparing a hole or groove in the humerus bone, and securing the tendon into the bone using sutures or anchors.
Right.
A de Quervain's release in the wrist involves carefully incising the sheath that surrounds two specific thumb tendons to relieve compression and pain. More complex procedures include tendon transfers, like an FDS slip transfer in the hand,
FDS?
flexor digitorum superficialis. It involves harvesting a slip of one tendon, rotating it, and attaching it to bone or another structure to restore function lost by paralysis or injury. A pronator teres transfer involves releasing the insertion of the pronator teres muscle in the forearm, freeing it from adhesions, passing it under the skin, and weaving it into another tendon to restore elbow or wrist function, rerouting things, basically.
Amazing anatomical engineering. And nerve repair is mentioned with some specific detail. Nerves seem incredibly delicate.
They are. Yes, digital nerve repair in the fingers is included. It involves carefully identifying the ends of the damaged nerve away from the injury, dissecting down to the injury zone, and then sharply resecting the damaged, starred ends.
Getting back to healthy tissue.
Exactly. The text specifically mentions resecting the neuroma on the proximal or hand side end, which is a painful, disorganized growth of nerve fibers at the cut end, and the glioma on the distal or finger side end, which is scar tissue at the end of the non-functioning segment. The goal is to reach healthy nerve tissue on both sides.
I see.
Then the healthy nerve ends are carefully brought together and repaired using minimal, extremely fine sutures like 90 or 80 nylon, thinner than a human hair to connect the epineurum, the outer sheath of the nerve, without tension. Confirmation might involve checking if the nerve repair line is taut when the finger is extended, which lightly tensions the nerve.
That detail about resecting the neuroma and glioma is really specific to the biology of nerve injury. Fascinating.
It's essential for successful nerve regeneration, giving the nerve fibers the best chance to grow across the gap. Finally, the book covers other procedures, like cord decompression, for early avascular necrosis of the femoral head.
We mentioned AVN earlier.
Yes. This involves using a hollow coring device, guided by fluoroscopy, to drill into the femoral head, stopping just short of the joint surface to relieve pressure and potentially stimulate blood flow, hoping to halt the bone death.
Right.
Bone cyst curettage is described, involving creating a small window in the bone's outer layer, the cortex, scraping out the fluid-filled cavity with a curette, sometimes using chemical agents like phenol or ethanol to kill the cells, lining the cyst, and then packing the cavity with bone graft.
Killing the hole.
Essentially, yes. And biopsies, both soft tissue and bone, are fundamental procedures described for obtaining samples to diagnose infections, sending them for microbiology or tumors and other conditions, sending them for pathology. Getting a diagnosis is often the first step.
It's remarkable how this textbook encapsulates such a vast array of techniques, each requiring its own specific set of steps and considerations, yet all linked by this underlying framework of methodical execution.
That methodical approach is the spine running through all these different procedures, isn't it? Ensuring that complexity doesn't lead to chaos.
So once the core surgical work is complete, the focus shifts to closing everything up and setting the stage for recovery. What is the text detail about these final steps? It's not over until it's closed.
Absolutely not. The closure and initial post-operative management are treated with the same level of meticulous detail as the earlier steps. A critical step before closing is wound management. This involves thorough irrigation of the surgical site with saline.
Washing it out.
Yes, the text often specifies copious amounts or even pulsatile lavage, using a device to spray saline with pressure, often for contaminated wounds or amputations, to clean the wound and remove any debris or small bone fragments. Ensuring hemostasis, Stopping all significant bleeding is also confirmed meticulously before proceeding with closure. You don't want anything bleeding inside.
And then the layered closure. Back out the way you came in.
Pretty much. Yes, the dictations consistently describe a layered closure, working from deep to superficial. The fascia, the tough layer covering muscles, is closed first using strong sutures. Then, the subcutaneous tissue, the fatty layer under the skin, is approximated to eliminate dead space where fluid could collect and cause problems. Finally, the skin is closed. A variety of suture types are mentioned depending on the layer and surgeon preference. Absorbable sutures like Vicryl or Monocryl for deeper layers, and non-absorbable sutures like nylon or Prolene, or even absorbable sutures like PDS for the skin. Different techniques are used for the skin-interrupted stitches, a running stitch, or subcuticular stitches placed under the skin for better cosmetic results.
And tension is bad.
Very bad. The text always emphasizes closing without tension on the skin edges, which is crucial for good wound healing. Too much tension can compromise blood supply and lead to breakdown.
What about drains and dressings? Are they always used?
Not always, but often. Drains, such as hemovac or other suction drains, might be placed deep within the wound before closure to remove any postoperative bleeding or fluid collection, which helps prevent hematoma and infection. Specific dressings are then applied to the closed incision. Steri-strips, those small adhesive strips, may be used to reinforce the skin closure. Various sterile pads or gauze dressings like biocclusive adaptic fluffs, sterile gauze, Zeroform, petrolatum gauze, or Tegaderm, a clear adhesive film, are applied, often secured with elastic wraps like an ACE bandage.
And then immobilization is frequently mentioned, casts and splints.
Post-operative immobilization is common, yes, to protect the repair or reconstruction while it heals. The type of cast or splint depends entirely on the procedure. A hip spica cast, covering the torso and one or both legs, for certain hip procedures.
Sounds restrictive.
It is. A long leg cast or splint for knee or tibia surgeries, a short arm splint or cast for distal radius or hand procedures, or even a cervical collar for neck fusions. The text often specifies the required angles of immobilization, such as keeping the knee flexed to 90 degrees or the elbow at 90 degrees to maintain the optimal position for healing or to prevent tension on a repair.
The level of detail really extends right through to the immediate post-op phase, checking everything again.
It does. The dictations also often include immediate post-operative checks and instructions. Essential checks confirmed before leaving the OR include palpating distal pulses to ensure blood flow to the limb is intact after positioning and surgery.
Crucial.
Confirming sponge and instrument counts are correct, often done ×2 by 2 different staff members for added safety, and verifying the attending surgeon's presence throughout the critical parts of the procedure.
Accountability.
Yes. Initial post-op instructions noted might include mandatory bed rest, elevation of the operative limb to reduce swelling, or specific feeding instructions for infants in hip spica casts. Checking cast tightness is also vital. Early check. Too tight is dangerous.
And then the beginning of rehabilitation is often outlined immediately, getting things moving again.
Yes, the text gives examples of the initial post-operative regimen. This often involves specific weight-bearing restrictions like protective weight-bearing or non-weight-bearing, sometimes for a specified duration like for 6 weeks. Early range of motion exercises are often initiated quickly to prevent stiffness.
Use it or lose it.
To some extent, yes. Examples include Codman pendulum exercises for the shoulder, just swinging the arm gently while leaning over active assisted range of motion, where the patient moves the limb with some help. Isometric exercises, muscle contractions without joint movement, or the use of a continuous passive motion, or CPM machine for knees, which gently bends and straightens the leg. Muscle strengthening exercises are also started early, with a plan for gradual increase in activity level outlined in the rehabilitation protocol.
So the meticulous planning and execution described in the book extend beyond the operating room and into the vital initial recovery period. It's the whole package.
It's a continuum of care, absolutely. And the text provides the blueprint for the entire journey, from diagnosis to early rehab.
Of course, despite all this precision and planning, surgical procedures carry inherent risks. The text lists potential complications for almost every procedure. Grouping these gives a clearer picture of the challenges surgeons and patients face. It's not always straightforward.
No, it isn't. And yes, the textbook is comprehensive and transparent about the potential complications, which are, of course, discussed with patients during the consent process. That's vital. These risks fall into several categories. There are general surgical risks that apply to many procedures.
Like infection, that must be high on the list.
Absolutely. Infection is always a significant concern. Mentioned as superficial wound infections, deep infections involving the bone or joint, or specific pin site infections around external fixators. Thromboembolic phenomena, the formation of blood clots, such as deep vein thrombosis, DVT, in the legs, or pulmonary embolism, PE, if a clot travels to the lungs, are highlighted risks, particularly after lower extremity or pelvic surgery.
Right. Clots are serious.
Very. Neurovascular damage, injury to those vital nerves and vessels we discussed protecting during dissection, is a critical risk, with specific nerves or vessels being listed as potentially vulnerable depending on the procedure. And wound healing problems are common potential complications. Dehiscence, where the wound edge is separate.
The wound opens up.
Yes. Hematoma, a collection of blood under the skin, delayed healing, or even necrosis tissue death at the wound edges.
Then there are complications specifically related to the hardware used or the bone fixation itself. The metalwork can cause issues.
Precisely. The text lists possibilities like loss of fixation, meaning the screws, plates, or nails fail to hold the bone fragment securely due to excessive force or perhaps poor bone quality. Malunion, where the bone heals, but in a poor alignment,
Healed crooked.
essentially. Or non-union, where it fails to heal completely, which is a major problem. Hardware breakage can occur over time or under stress. Screw penetration into a joint surface is a risk, for instance, when fixing fractures near joints like the femoral neck. Component loosening is a long-term risk, particularly with joint replacements, where the implant can become unstable over years. Implant position issues, like placing a joint replacement component in varus bout inwards or valgus bout outwards alignment, or overstuffing a joint with implants, are also potential complications impacting function and longevity.
And complications specific to the bone or joint being operated on.
Beyond the hardware, yes, these are numerous. Joint stiffness is a common outcome after many procedures, particularly affecting range of motion in the shoulder, knee, or neck after fusion. Recurrent instability or subluxation partial dislocation can happen after ligament or capsule repairs, meaning the original problem comes back.
Frustrating.
Very. Failure of the repair or the healing process itself is a possibility. Failure to achieve the primary goal, such as failure to relieve the patient's pain despite a technically sound surgery, is also listed. Sometimes the pain just doesn't go away. Post-traumatic arthritis, developing later in life in a joint that was injured and surgically repaired, is a long-term risk. A vascular necrosis, the death of bone tissue due to blood supply loss, is a specific and serious risk mentioned for procedures that compromise blood flow, like cord decompression or certain fracture fixations in the femoral head or scaphoid. And sometimes a new fracture can occur during the surgery itself or in the post-operative period.
It's a comprehensive list that really brings home the potential downsides even with expert care. Surgery is never risk-free.
Not at all. And the fact that the text explicitly notes these are discussed with the patient during consent underscores the gravity and necessity of informed decision-making before surgery. Patients need to understand the potential trade-offs.
This deep dive into the world of orthopedic surgery, guided by this comprehensive textbook, has truly illuminated the level of precision and systematic thought required. It's quite incredible.
It highlights that this isn't just about skilled hands, is it? It's built on a foundation of meticulous preoperative assessment and planning, navigating anatomy with extreme care, executing complex steps with precision, constantly protecting vital structures, and documenting everything rigorously from start to finish and into early recovery. The textbook serves as a vital distillation of accumulated wisdom, standardizing the best practices learned through countless hours in the operating room.
It provides a structured roadmap for operating within the complex mechanics of the human musculoskeletal system, with the ultimate goal of achieving predictable and successful outcomes by minimizing variability and error, getting it right consistently.
Absolutely. And thinking about this required level of detail, the standardization, the systematic approach demonstrated here, what does this profound focus on process and precision in surgery tell us about mastering any complex practical skill or profession, even far outside the medical field? It makes you wonder.
It suggests that true mastery isn't just about raw talent, or even just putting in the hours, perhaps. It's about breaking down intricate tasks into definable, repeatable steps. Standardizing those steps based on proven experience and evidence, relentlessly focusing on the smallest but most crucial details, planning meticulously for potential challenges, and building a clear, documented modus operandi that can be taught, replicated, and continuously refined. It's about building a reliable system around the individual expert, maybe, making excellence repeatable.
A powerful takeaway about the nature of expertise itself, I think. It's systemized skill.
A fascinating thought indeed. Thank you for guiding us through this intricate world. It's been eye-opening.
It was a pleasure. Always fascinating to delve into the details.
And thank you, our listener, for joining us for this deep dive. We hope you've gained a new appreciation for the hidden complexity and precision behind seemingly simple actions like walking or lifting. If you found this interesting, please consider rating and sharing the show so others can discover it too. We'll be back soon with another deep dive into source material you provide.